As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, open the Q&A text box, and when you have finished typing your question, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information. Our speakers cannot answer any specific questions related to your child's health care. During this session, there will be a poll for the audience to respond to using the polling icon on the right-hand side of your screen. Please feel free to take the poll should you choose. Today's specialists are Sheila Dodds, who's a hospital social worker at the Children's Hospital of Wisconsin, Jennifer Haig, who is a psychologist at Children's Hospital of Wisconsin, and Jill Farner, who's a child life specialist at the Children's Hospital of Wisconsin. With that said, it is my pleasure to welcome Sheila, Jennifer, and Jill. Thank you all so much for joining us today.
Thank you, Lee. Good afternoon. My name is Sheila Dodds, and I'm speaking to you today from Milwaukee, Wisconsin. I'm a social worker at the Children's Hospital, and I'm here with two of my colleagues, Jill Fauner, child life specialist, and Jenny Hoig, psychologist. So for the next hour, we are each going to take a little bit of time to address from our professional perspectives on the topic, parenting a child with bone marrow failure. The three of us have many years of experience in working with children with bone marrow failure. One of our physicians we work with is Dr. Dave Margolis. Some of you may be familiar with Dr. Margolis from his recognized work in the world of aplastic anemia. We would like to thank Dr. Margolis and Lee Clark from the Aplastic Anemia MDS International Foundation for asking us to speak at today's outbreak session. So our one disclaimer is that even though Jill and Jenny and I have experience in working with children with bone marrow failure and their families, we do not have all the answers. We will be sharing our insights for what has worked well, or sometimes just as importantly, what has not worked well when supporting a child with bone marrow failure and their families, so that you can all avoid some of those pitfalls. We recognize that you are all at different points in this journey. Some of you may have a child that was just recently diagnosed with aplastic anemia or MDS. And some of you may have a child who is years post a bone marrow transplant or immune suppression therapy. So you may find some of the information relevant and other pieces not so much, and that's okay. Every year, we get a number of patients who travel across the country to our hospital to be under the care of Dr. Margolis. As a social worker, I frequently remind parents that no matter how well Dr. Margolis and his team knows how to treat their child's aplastic anemia, nobody knows their child better than they do. As a result, they are empowered and recognize their role as being just as important. If there is one thing we would like you all to walk away with from today's panel, it's a feeling of empowerment, that you are all experts as well. And we really applaud you for you being your child's advocate and for seeking more answers by participating in today's virtual conference. So one of the downsides of a virtual conference is just that lack of engagement between the speaker and the audience. But just like Lee said, we really want to remind you to feel free to put in the chat questions you have, or we may be talking about examples. Feel free, even if you don't have a question, if you want to add your insight or experience or example as well. So that way we can all learn from each other. So when I began organizing my thoughts for today, I was really struck by how many challenges you have all experienced by being a parent of a child with bone marrow failure. Some of these challenges I've listed may seem really obvious, but I really believe there's true value in reflecting on what makes your experience more unique. So I'm going to go through the list, but please feel free, like I said, to share examples you may have. Let's start with the treatment plan. I think one of the uniquenesses of a diagnosis of bone marrow failure is that treatment may be determined and really executed really quickly. Such as we may hear a story from a parent that tells us a week ago their child was showing bruising. A day later they were in clinic. 2 days later they were having a bone marrow test and they got a diagnosis of aplastic anemia. And 3 weeks later they're having a bone marrow transplant. So as a result, our patients and families experience what we call information overload, where they're trying to process and trying to get their head around the diagnosis and treatment plan, and things are moving really quickly. So in addition, you may not only have your child with the diagnosis of a bone marrow failure, but you may be facing a bone marrow transplant that includes a sibling donor. So this results in some of you having to multitask and take care of not only the needs of your child who's got the diagnosis, but your child who is preparing to be a donor or during that donation process. Another example is really the lack of knowledge about the diagnosis in the general public. So your child's been diagnosed with a condition called bone marrow failure, aplastic anemia, or other types of bone marrow failure. And so it isn't cancer, but it's treated like cancer and is life-threatening like a cancer. Yet when you tell somebody about your child's diagnosis of, let's use the example of aplastic anemia, due to the lack of knowledge, their response may be, oh, I've heard of that. You treat that with iron, right? And then you find yourself, you find yourself as the role of educator, and you're trying to attempt to teach your extended family, friends, school community about not only the medical condition of your child, but just the significance of what that medical condition is. Then we have the disruption of activities of daily living for real long extended periods of time due to your child's diagnosis. And I think this too can get lost in translation, especially when it goes on for months or a year or more, where family or friends just make assumptions that, oh, well, it's the holidays, your child will be able to participate in some of the activities, right? And you're trying to educate them that when you have a child that has a compromised immune system, holidays or no holidays, they're not able to participate. And so I think sometimes what we hear are the challenges of the length of time with the disruption of activities of daily living. And then also what comes with that is isolation. I think that it's common for extended family, friends, community to rally at the time of diagnosis, but then life gets back to normal for them, not so for you. And so isolation can kick in as the time goes on. And then there's the limited financial resources. As a social worker in the hospital, I'm very well aware of the difference between the amount of financial resources there is for a child or a family that has a child diagnosed with leukemia versus a child diagnosed with a bone marrow failure. And so that can be really almost insult to injury, because you all as parents and family members are dealing with just as stressful and scary and a vulnerable time, yet there aren't the programs always out there to support you. So given these challenges, I think it's even more important to be successful in navigating through the medical system. Given the stress you're under and trying to successfully care and advocate for your child. So just a couple tips I have with navigating is identify your team. There's a lot of obvious members of your team, obviously the doctor and the nurse, and maybe the discharge planner, but you definitely want to advocate and inquire who else is a part of this team. Here at Children's Wisconsin, we have a large psychosocial team. We recognize not all hospitals have as much support staff. Our team is made up of psychologists, child life specialists, social workers, school teachers, chaplains, but you definitely want to inquire and utilize your village, as we tend to call it here at the hospital, and utilize the different experts that can provide support to you, or provide support to your child, or provide support to your other children. You also want to clarify the communication practices. And it could be as simple as, does your doctor and team prefer to utilize MyChart to communicate, or phone calls instead? Or the difference of how is communication done on an outpatient basis versus inpatient? For example, when we have kids in the hospital, we involve those parents in our daily rounds. And so the bone marrow transplant team engages with the parents, not only during rounds where that's utilized as more teaching purposes for the residents and the team involved, but then they come back later and communicate to the parents again in the room. But you don't want to have assumptions. And so one of our jobs is to educate parents on what those expectations are when a child is hospitalized. And so getting clarity on communication styles and processes can be really helpful. Also clarifying expectations. When a test or lab work is done, how soon will you get those results? Will you get a phone call if there's concerns about results? And how much do the medical team expect you to communicate to them on a regular basis, especially when you're managing your child's care at home? So those are just a few tips that we have found to be helpful when we're educating parents in, especially with both the inpatient when their child's going to be hospitalized for a long time, and then transitioning to the outpatient world. I am now going to have my colleague, Jill Fauner, talk to you from the perspective of a child life specialist.
All right. Well, thank you, Sheila, for the introduction and transition. So like Sheila said, my name is Jill Fauner, and I'm one of the child life specialists here in our Mac Fun Center Clinic for Cancer and Blood Disorders. So for those of you who might not know what a child life specialist does, we are clinically trained professionals in the field of child development, and we're here to recognize the impact of various illnesses, including bone marrow failure. Child life specialists focus on teaching healthy coping strategies. So we use a lot of different modalities in order to do that. We do a lot of hands-on medical play, preparation, make sure that we're using developmentally appropriate language to explain diagnoses and procedures. And we also provide distraction and support during these procedures that could be potentially painful. So the overall goal of Child Life is to provide family-centered care in supporting our patients, families, siblings throughout their medical experiences and diagnosis. So I know that's a very wordy slide, but trying to kind of fit in the multifaceted areas of a child life specialist in a nutshell. So our main goals are to decrease stress and anxiety surrounding getting the new diagnosis, surrounding various procedures. I know Sheila touched on that a little bit, that once things kind of start moving, you come to the hospital, there's a lot of clinic visits, there's a lot of lab draws. Depending on things, there's various scans and things can move kind of quick. So our role as Child Life is to help partner and make sure they understand what's going on and help decrease the stress and anxiety, teach them some healthy coping skills and strategies, and make sure that we're helping with mastery and understanding with the new diagnosis. So some of our interventions that we used, I touched on a few of these already before, but our main goal is to focus on developmental assessments. So we recognize as child life specialists that the age we see on a piece of paper, whether that be 7 or 17, might not always fit developmentally. We have some patients on a wide spectrum of developmental levels, some with delays, and some that are developmentally appropriate. So we are here to help recognize where patients are at and meet them where they're at, and then tailor our interventions to make sure that we are giving them what they need. We do a lot of diagnostic education. So we have various hands-on teaching tools. We have our teaching dolls that have various PIC lines, CVLs, and ports so that we can help teach patients if they're going to get a line placed. We do a lot of procedural preparation and support. So there's a few of us, we're very lucky to have several child life specialists scattered throughout the hospital, both in imaging and day surgery. So we oftentimes partner with them if patients are having a line placed to make sure that support is carried on through there. We help facilitate emotional expression through various activities. We'll meet with patients and siblings bedside to do various art activities, games, and kind of help normalize the hospital environment. We want to make sure that we're developing healthy coping plans. So if patients and parents are able to recognize various stressors that are hard for them, various procedures, we can sit down and work with them on different coping plans, teach them about some of the non-pharmacological pain management strategies we have available to make these things a little bit easier. We can also help with medical compliance and pill swallowing. So some patients come to us, have only taken liquid medicines, and then depending on the dosing they get, it can be a lot at times. So we kind of help teach pill swallowing to kind of eliminate that stressor. We help normalize the hospital environment through various events and special activities going on in the unit. And we also focus on sibling support. We know that siblings can sometimes be the forgotten ones at home, and we want to make sure that we're touching base with parents, seeing how the siblings are doing at home, seeing what questions they have, and making sure they have all their questions answered. So healthcare team collaboration, it's another thing Sheila touched on a little bit, is that there are many members of the medical team and many members of the psychosocial team, and we have very shared goals for patients and families. But the resources and methods we use kind of vary depending on our area of expertise. So that's why we're all here to collaborate with one another, to talk through patient family needs and kind of see which would be most appropriate to provide that support. And we just work together to meet the family's unique needs, meet them where they're at, and make sure they have the support that they need to get them through what they are going to encounter. So in these next couple slides, I'm kind of going to be touching on the various developmental levels of children and some medical stressors that can pop up depending on where they are at diagnosis and in treatment, and kind of ways that you can help as a parent, and ways that we can get our nurses, child life specialists, care partners, kind of anyone on board to help make these procedures a little bit less scary and traumatic for patients. So for our young infants, they are in the trust versus mistrust category of development. So in this stage, they're really learning which adults they can trust and who comforts them and who they're a little bit fearful of. So some of these common stressors within the hospital environment is separation anxiety. That is a really, really big one for this age. Infants want that comfort and attachment with mom and dad. We know that you guys are oftentimes juggling jobs and other children at home. So depending on the length of hospital stay, can't always be here all the time. So that's where child life specialists will partner with our volunteers, help provide comfort and play and stimulation at bedside if parents aren't here. So other ways that parents can help is advocate to be included. We see in this picture off to the right, a mother in a comfort hold with her infant during immunizations or other kinds of shots. So definitely advocate to be included as much as possible. You know your child best and you are their greatest comfort. So be sure to advocate. I always try to teach our care partners and nurses about the 4 S's during procedures. So that is swaddle, shush, swing, and suck, as these are all positive coping techniques that infants use in order to calm, self-stim, and get themselves through things that are uncomfortable. Another thing we try to do if patients are in for a long period of time is schedule kind of that fine and gross motor play time. We can partner with PT and OT and get things scheduled, making sure that we're getting tummy time and play and all things to make sure that that normal development is being met. And also maintaining a routine as best as possible. So having good sleep-wake cycle and making sure that that's posted in the room somewhere so that everybody knows what nap time is, or if it's reading time, tummy time, getting those schedules on board. Our 1 to 3-year-olds are very fun ones. This is probably my favorite age group. So patients in this age are in the autonomy versus shame and doubt. So autonomy, they're learning about their environment, learning through play, they're exploring, they're learning new skills on the daily, or learning to jump and skip and run and play. And finding those things that they can master at. Or are we a little bit more fearful of things? We've kind of held back and we're a little bit more shy. We're a little bit scared to try things. So some medical stressors, again, are separation anxiety. We see that a lot with our 2, 3-year-olds come to clinic and kind of hide behind mom and dad's leg, not wanting to get to know people, and stranger danger. So those are the main things that we try to keep in mind. As you see, the child life specialist in the picture is down on their knees. So getting down to the patient's eye level. So we're not always kind of towering over them. We're including mom in another comfort hold during an IV placement, as you're going to provide the greatest comfort. So with this age group, we do a lot of the show and tell with items. We want to show them what we're going to be using, what it's going to do. And then we also use distraction and comfort and offering them some fair choices. We're going to look for a place to put in an IV now. Do you want to look on this arm first or that arm first? So very appropriate choices. Getting an IV placed isn't necessarily a choice. That's something we have to do, but we do want to offer them some choices if and when available. So our preschoolers are 3 to 5. They're in the initiative versus guilt stage of development. So here medical play is huge. You can see that in the picture there, the patient giving her mother a shot, working through kind of the show and tell of things that they've seen during their clinic visits, that practice and reteach of things they've seen, things they've had done. So medical stressors here oftentimes are a loss of independence. We see our 3 to 5-year-olds wanting to get dressed in the morning and pick out their own clothes and decide what show we're going to watch on TV. So they're definitely independent, and oftentimes that's taken away within the hospital environment. We have a lot of things scheduled that they wouldn't necessarily have and that aren't a choice and kind of have to happen. We also tend to see some regression in milestones. So depending on age, the child might have already been potty trained and then might have regressed a little bit into having more accidents and things like that while in the hospital. So we always try to keep an eye on that and kind of see what stressors have popped up, different things that we can help with. And medical procedures are seen as punishment. So some children will come to the hospital apologizing for getting in an argument with their brother and they didn't mean to and they won't do it again. So kind of seeing these procedures as punishment and rephrasing what we're doing and why we're doing it. And it's not as punishment. It's not anything you did wrong. We're here to just figure out what's going on and get you medicine and things to help. Ways mom and dad can help is prepare with the tell, show, do approach. So we're going to tell them what we need to do. We're going to show them the steps if we're able to partner with nurses and show them everything ahead of time. And then we're going to do it. So we'll come up with that plan where we're going to sit, what we're going to use. We oftentimes use counting and visual blocks kind of in that lower corner. We see the patient engaged in the tablet. It's a very popular thing at this age. So depending on the developmental games we have on there, we can kind of keep their attention on that. Praising for specific behaviors, and then again, maintaining a routine as best you can. So school age, our 5 to 12-year-olds, they are in the industry versus inferiority stage of development. So here they're definitely starting to learn what they're able to master, what they can do. We have more peer interactions at school. We're learning about friendship relationships and starting to feel a little bit more comfortable in our own skin. So some medical stressors, body mutilation and harm, again, questioning whether this IV is going to change how I look. Is it going to be super painful? We get that increased fear of pain at this age group. And then again, a loss of control and independence. So at this stage, they're doing a lot of things on their own, and we're coming into an environment in which we're kind of taking some of those choices away and some of that control away. But ways we can absolutely help, offer preparation. Again, hands-on medical play is seen in the picture. We want to encourage them to ask questions. So tell me what you think that might feel like. Tell me a little bit about the lab draw you had last week. What worked well? What didn't work well? So really involving them in their care. Engaging them in the creation of their own coping plan. So when you come to lab next week, what do you think we should have there? Should we use Buzzy Bee or our Freezy spray, other things like that to kind of help? Are you gonna pick a new game with mom and sit on dad's lap? So kind of encouraging them to create their own coping plan. And again, maintaining a routine. That's kind of a redundant thing that I have on all these slides, but really a routine is one of the most important things. If your child's going to be hospitalized for an extended period of time, making sure they have that predictability is really, really big. So lastly, we have our preteens and teens. They're in the identity versus role confusion phase of development. In this stage, they are definitely finding out who they are as a person. They're kind of questioning their own morals and feelings on things. Or are we a little bit confused? Do we not know who we are yet? Do we not know who our friends are? I agreed with this person and not that one. So we're really getting into the in-depth mindset of processing everything. So some medical stressors for teens is we have separation from peers, and the disruption from hobbies and extracurriculars. We can kind of see this as a huge thing. They've set their friend group at school. We know that this past year, 2020, it kind of separated everybody and made everything virtual, isolated everybody. And that was really big with our teen population. It just was not the same. We're not engaged in sports. We don't have that, those other things to look forward to. And then we have the threat to current and future competence. So is this diagnosis going to change everything that I thought I knew about where I was going, what I was doing? I'm going to have to learn a lot of new things. And it's kind of, it can throw a curveball. So ways we can help in the hospital and ways you can help as parents are engaging them in that care planning and in those conversations. I know a lot of times we're a little bit hesitant as adults to include children in these conversations. What are they actually going to understand? It could be really scary to talk to them about this, but really involving them in the planning and conversations can be huge. They can ask their own questions, have preferences. Honoring their choices is really big. If teens are a little bit hesitant on something or have deeper questions, kind of taking that pause and really talking to them about what's going on. And try to keep a consistent sleep-wake cycle. So this can be hard in the hospital, really, really hard. Teens just want to sleep through the day. It's kind of that avoidance coping. If I sleep, no one's coming in here. I don't have to talk to anybody. And then we're up on our phone 2, 3, 4 in the morning, scrolling through Facebook, looking at TikTok, all kinds of things. So we kind of get that big disruption in the hospital, but we want to make sure that we kind of limit screen time, make sure that it's happening at appropriate times, and making sure they're getting that sleep and being involved in their morning rounds. So being awake at that time is pretty helpful. Another huge thing that we do is support for siblings. I did touch on this a little bit at the beginning, but I'll kind of wrap up my main things by talking about siblings. So keeping them involved in family conversations as best you can. It's really important to keep them in the know as much as you can, letting them know these things are going to change. Mom and dad are going to be at the hospital a little bit more with brother or sister, and really just keeping them involved and not on the outskirts. Set aside time to go on an outing with just them, to just have time with them, so they know that they're still important, they're still heard, and they still have time with mom and dad that they might not have gotten a lot. Provide with opportunities to share their feelings and give a safe space to do so. One of my previous patients' families, they would have on every Thursday night kind of like a sit down question time. They would just all circle up, what questions does everybody have? Where is everybody at? What are you feeling? How was your week? Just having that check-in time and giving them a safe space to talk about their feelings, even if they're angry or frustrated. It's a good way to get that out on the table and then kind of talk through ways that they can help. Keeping routine as familiar as possible. I know oftentimes with jobs or diagnosis, how long you're going to be in the hospital. A lot of our families rely on their extended families, aunts, uncles, grandparents to kind of take over things while you're spending time with patients in the hospital or at clinic. So as much as you can, keeping a consistent routine, at least making sure that it's predictable, it's written on a whiteboard somewhere for the week so they know where mom and dad are, they know what time things are, just so they're in the know. And then even at school, letting teachers know, kind of giving them the heads up of what's going on, and that sibling might be a little bit off in the classroom. If they have school counselors, kind of letting them know and being another safe person within the school to talk to if they're having a difficult time. So I won't read through all of these, but kind of how I did in the previous slides where I separated into age group, we have the same resources here for siblings, kind of where they're at developmentally in their understanding, common fears and behaviors, and then ways that you can help at home support the different age groups. So we have that for our school age and adolescents as well. So that kind of concludes my piece. I know it was a lot, but we are ready to hand it over to Jenny Hoig and kind of talk about self-care and things from a psychology standpoint.
Okay, so we've talked a lot about how to support your children, and I find that this is everybody's sort of priority. It's the thing they want to talk about the most, and while I appreciate that, I think it's also really important to recognize that as the parent going through this, we know that you are scared, you are overwhelmed, you are probably exhausted. And there's going to be different ways that you cope depending on sort of how far you are from learning about this, where you're at in the treatment plan, and just other things that may be going on. So one of the things that I like to look at is, just sort of giving you a framework for what, like, sort of where are you at? How do you know what supports that you need in that time frame? So this Kubler-Ross change model is one of those frameworks, and it grew out of the 5 stages of grief, which I think many people are familiar with. It was, it's been popular in media, and in that there was these kind of 5 stages. They were denial, anger, bargaining, depression, and acceptance. And people often presented those as if they were kind of linear, like you have to hit this stage and then that stage, and that's the way that it happens. But we know that that isn't true. People kind of flow back and forth between different stages. And there's more than that when we're dealing with change, whether that is the loss of normalcy, new diagnosis, scary information. So I think that this change curve gives us a good sense of kind of, what to anticipate and to some extent when. So we start with that first part on the left where we look at shock and denial. This is kind of the first stage that we anticipate families going through. At this point, we know that your morale and your confidence in your ability to parent probably is going to dip quite dramatically and quite quickly. Normally, if you are somebody who is pretty decisive, you make decisions easily, you can anticipate that during this time, you're going to need more reassurance, you're going to need more guidance from people. After that initial shock has sort of worn off, it's common for parents to go through a period of denial. And this isn't necessarily like I'm pretending this isn't happening, but really more going through a period of disbelief. You might hear parents say, everything was fine before. My child was fine. My child was healthy. Like, why is this happening now? Why does this have to happen to our family? I think at this stage, one of the best things that families can do is really seek additional information, additional medical information. And that's where that communication with your medical team is going to be really key. Your medical team can go over information with you so they can reiterate information, even if you've already heard it, because as Sheila talked about, there is this kind of information overload. And we know that there's a point at which you cannot continue to digest new information. So if the conversation is an hour long, you might only really follow or digest about 10 minutes of that conversation. And so our medical team and your medical team is going to be aware of this, and they're going to know that they need to go over information with you on several different occasions. If you have kind of a trusted other, somebody who's maybe like sort of a step outside of your inner circle who can come with you to some of those conversations and take notes for you, that can be a really helpful experience, a way to kind of review the information after that meeting is over. One of the things that I really strongly discourage at this time is Googling information. Like, Google is not helpful. Dr. Google, stay away from Dr. Google. There are too many intricacies in treatments. There are too many differences between different kinds of diagnoses, the ways that different providers might treat that specific disease. So the person and the people that you want to talk to are your medical team, not Googling information to see what else might be out there. The next stage is anger and depression. So after those sort of initial feelings of shock and denial wear off, we can expect that there's going to be a phase of anger. This is a time where there's often kind of a scapegoat. So maybe you're really mad at your pediatrician for not picking up on the symptoms sooner. If there's a genetic component to this disease, perhaps you're really angry with yourself or you're angry with your partner. Focusing the blame on someone else or something else can often give us a place to kind of focus our fear and anxiety that diagnosis is causing. It's generally, though, not incredibly helpful. And it may be then to the sort of the detriment of your day-to-day tasks that you would otherwise be able to get done. So I worked with a family recently. Their child was relatively newly diagnosed within the last month or so. And this child was in the hospital in isolation. And the parent was very, very angry that their child was being expected to stay in isolation and felt that that decision was really the reason that their child was struggling emotionally. And rather than kind of addressing that and looking for strategies to help their child's mood, this parent kind of used this scapegoat of isolation to fight against a hospital policy that probably is not going to change, was kind of a losing battle, but really kind of, misdirected that anger in a way that didn't allow the parent to kind of help their child in the moment. I think that this is a really important stage for reaching out to the supports that you have. So it's a really good time to reach out to this community, this bone marrow failure community. It's a great time to identify your hospital care staff, the people in the hospital that you feel like you can talk to, and get reassurance. Know that many of the things that you're experiencing are normative. You may need a place to vent through some of this anger, and then also to have some people to help give you some different ideas of how to approach the situation in a way that might be more effective. And then in the last kind of part of this change curve, we have acceptance and integration. So in this stage, we find that there's kind of a more optimistic mood that emerges. You maybe will forever not like that this change is the thing that has happened, but you may accept that the change is inevitable and it's here. So you kind of begin to work with the changes rather than against them. And that can really help you get to a place where you feel a new sense of mastery over your child's illness, a new sense of predictability. You know, kind of what to anticipate when you come to the clinic, your providers, just, kind of a better sense of, my child has these symptoms and here's kind of what we're doing to treat them. The final step is integration. And that's really when the focus really shifts to the future. So by the time that people reach this stage, having a medically ill child in treatment is often really a new reality. And there's an acceptance of that reality and feeling more hope about your child's future. This is a good time, I think, to kind of settle into this new normal, take advantage of the good days that you have and celebrate whatever milestones there might be, even if they sometimes seem like small milestones, like getting your PICC line out. I think those are really important things to celebrate and to recognize that you're making progress. So because we know this is so incredibly stressful, obviously we are going to, and you will hear from your psychosocial supportive care team, that you need to practice good self-care. So what is good self-care? Well, it's not selfish to have good self-care. It's not selfish to take care of yourself and to give yourself a little bit of time each day. And during that time, what we're looking for is for you to pay attention to your own physiological and physical health and wellness, and then do something about it. So not just recognizing I'm not taking care of myself. That's the first step. But the second step is to more actively do something to make those changes. So I think many people think of self-care as kind of cliche. It's impossible. I don't have any time. How would I ever squeeze this in? And I think there's, to some extent, I think popular media has been to blame for this, talking about self-care like it is, getting a manicure or massage, like that's what you have to do to take care of yourself. But I think it's often so much more than that. And I think most importantly is recognizing that it's a process. So this is not something that is going to be done overnight. The process of creating habits of self-care is sometimes actually more important than what those habits actually are. So one of the first things we recommend is to build in rest. This really cannot be stated enough. Rest is not an escape from the things that are stressing you out. It is an opportunity to kind of recover from those stresses and allow yourself to then reemerge from that state of rest and be more ready to take on what's ahead. I know as parents, we often want to accomplish everything. We want to push and do our best. We want all of our kids to live happy, healthy lives. We want to live up to expectations in our careers. We want to stay connected to our partners, but taking on too much in this moment of kind of crisis or in the midst of your child's illness is probably going to be a recipe for burnout. So instead, it's important to set some priorities, establish some realistic, sustainable goals that are going to help to feed your self-care. So for example, a goal for the week might be, instead of just packing my child a water bottle and some snacks when we go to the hospital, I'm going to pack myself also a water bottle and some snacks. The important part is that you start small and that you experience some success following through. Another way that we know that you can help to create some of these habits is to pair a self-care habit with your regular routine. So as an example, I like just thinking about my own personal life. One of my most dreaded tasks is folding laundry. I don't know why. I just really, really hate folding laundry. So I actually have started to pair folding laundry with using those 15 minutes to listen to an audiobook. So that's one way that I have to spend that time doing the laundry anyway, but I can actually pair it and use that opportunity as a time to do something that I enjoy and that I find restorative. If 15 minutes feels like a luxury and that feels impossible in your schedule, it doesn't have to be that. You can, again, using the laundry as an example, you can pick up a piece of your clean clothing and you can just, sort of smell your fabric softener or whatever it is, and take a few deep, slow breaths and allow that to be part of your self-care routine. One thing that I want to just stress is that I think people often think that self-care is only working if you immediately feel better. And that can dissuade people from really trying it. Remember that the most important part right now is the habit, developing the habit, not necessarily the outcome. The outcome may come later. Think of it as healthy, sort of healthy eating. We know that eating fruits and vegetables over the course of your lifetime is going to lead to, healthier, better health outcomes. And that's really what self-care is as well. You may not feel immediately better, but over a matter of time, there will be relief. So there are lots of different ways you can take care of yourself. I just put some ideas down here just to give you a sense of, kind of what are some of the things that I think about. So that might be limiting the intake of overwhelming information. So staying off of social media, staying away from Dr. Google. Set boundaries around your medical updates. This is one that I often recommend to families. After a child is diagnosed, there's often multiple people stepping forward to provide you with support. And that can be wonderful, and it can also be overwhelming. So I often suggest to families that rather than field, 20 calls a day or ongoing text chains, that what they do is establish one place to provide updates and leave it at that. Kind of let that be your boundary. This is where I leave up-to-date information. If you haven't heard from me, I may not want to be contacted. I think this is also a great opportunity to prioritize family activities that bring you joy. So if you love to go on a bike ride and you feel like that's a fulfilling way of caring for yourself, offer that to your family as something that you do together. Getting outside has a number of benefits and is another great self-care idea. Finding one thing to be grateful for each day. That doesn't have to be something big. It doesn't have to be something that really necessarily stands out as amazing, but really just being grateful that your child slept through the night, being grateful that you had a warm cup of coffee in the morning. Connecting with friends can also be a really helpful part of your self-care, as can be crying, giving yourself an opportunity to feel your feelings and sort of work through them or express them, knowing that opening that up doesn't mean you're opening up the floodgate and you can never close it again, but that you can sort of allow yourself to feel stuff and then to be able to kind of close that door and move on to other activities. And if all else fails, if there is no time in your day and you really don't think that you can do anything related to self-care, think about NESS. NESS are nutrition, exercise, sleep, time for self, and support. Find one of those, pick a letter, and try to identify something that you can do to take care of yourself.
Thank you, Jenny. So I'm going to finish up our talk today with going through some resources. And just to piggyback off of something that Jenny talked about, how supports can be a little bit double-edged sword at times. There are times you need your village to be there and to support you. And at times it's okay to feel like I have no energy for my village. And so I'm often telling parents that it's okay to pay attention to who gives you energy and who takes energy from you. And when you are on information overload or exhausted from the routines and the daily cares that your child needs and being a caregiver, it's okay to set limits and pay attention to, I don't have time to take that call from, let's say, Mary today, because Mary requires as much energy as she gives. And so I always say, pay attention to who gives you energy, who takes energy, and where are you at, as well as not only people, but situations. Is going to a Brewer game something that's going to give you energy, or are you on the Milwaukee Brewers? I'm sorry, I just realized I'm talking to people around the country. Are you exhausted and a baseball game is going to take more energy from you, or would you benefit more from a quiet evening at home taking care of yourself? So right now I just want to touch base on some resources. I alluded to earlier in my talk that there's limited financial assistance programs compared to other diagnoses. That is true, but you do want to just be aware that there are programs out there, and you want to tap into your village or your team at the hospital. If you have a hospital social worker, that's what I would recommend, because we have, for example, here in Milwaukee, we have some foundations that are specific to not only oncology or a child with cancer, but it includes bone marrow failure diagnoses as well. And so sometimes I think the best people to ask or inquire about financial assistance programs can be the social worker or your team, the nurses at your medical center. And definitely the bigger name programs like Be the Match, they have some great financial grants if any of you have a situation where your child's having a bone marrow transplant or had a bone marrow transplant utilizing an unrelated donor. Once again, I can't reiterate enough, utilizing the psychosocial team. The doctors and nurses are not only great clinicians, they're great to provide support, but you want to, they also only have so much time. So you want to get clarity on, are there other people within the medical center that you can utilize to help support your child, as Jill pointed out, or your other children, or as Jenny pointed out, to help take care of yourself so that you can continue to be a caregiver. School staff. We are spoiled here in that we have school teachers based in our hospitals. So we have the advantage of utilizing school teachers, but we also utilize the team of school staff where our patients attend, or they may not be attending in person at the school, but some of that, the school staff can be tremendously helpful in coming up with resources to support your child throughout treatment or post-transplant. You also want to utilize, if any of your kids have had neuropsych testing because of a bone marrow transplant or because of the treatment plan and the diagnosis, you definitely want to take advantage when offered of neuropsych testing, because you can get a wealth of information about your child's strengths and areas that are more challenging. And the school then can utilize that in their educational plan. And then you, as you are today, I just want to point out again, you are there taking care of yourself today by being a participant in today's virtual conference and taking advantage of the programs that aplastic anemia, myelodysplastic syndrome International Foundation offers. So kudos to you for taking time of your day to be present. So I don't know if there are questions or comments. Like I said, we can learn from you as well. If anybody doesn't, if you don't have a question but have a comment, please put that in the chat and we can respond from our experiences as well.
Thank you guys so much for the wonderful presentation and lots of information to help patients and families. So we do have a few questions. The first question is, how do you know what is normal when your child does not want to discuss their illness? What's normal for adolescents to not discuss that? And how do you know when it's, say, something that you need to seek assistance for? What's normal denial? And then when is it to the point where you need to seek outside help?
Let me see. We're going to have Jill respond from her expertise.
No, Jenny and I were kind of looking at each other on that one. That's probably an area where I would partner with psychology a lot. So yeah, you're correct. Wondering how your child is going to process the information, how they're going to react, and making sure you're able to know what those red flags are and what is completely normal. So it kind of depends on developmental age and level on where they're at. So we do see a lot of times with our younger children, that they're kind of the here and now processors. So you could tell them something and then 2 seconds later, they want to go back on their tablet, they want to read. So it's kind of here 1 minute, gone the next. And you're absolutely correct with teenagers. They're kind of those quiet processors and can be kind of hard to read sometimes. So from at least my experience, a lot of what they are thinking about inside their heads can be way worse than actually having an open conversation with them. And it can be a little bit difficult to just kind of sit back and wait. But sometimes that's the best, is giving them opportunities to ask their questions, always presenting that, involving them again in kind of those medical conversations. Even if they're younger in age, you can have a psychologist, a child life specialist present at bedside with the medical team during those conversations. And we can kind of help read and gauge the child's reaction. If we see them kind of sitting back or wincing at something, we're like, oh, it looks like you might have a question about what we just said. Or do you want us to go in a little bit more detail and answer those questions? So it's kind of reading them where they're at. But I know the sitting and waiting can sometimes be really, really hard for them to open up. Sometimes they might, and sometimes they might not. But giving them opportunities to journal, I think that's always good if you know that your teenager or child is kind of one of those internal copers, providing them with resources, a new journal, a new notebook. They can kind of write questions down. I'll sometimes offer that. So I'll go through some hands-on teaching and then say, here's a notebook. You can write down questions and then I can just read those myself and I can answer them. You don't have to ask them to me verbally yourself. I can read them and go through that. So it's kind of, again, just partnering with who you have available. And I don't know if Jenny had more to add.
I think the only thing that I would add is there are some kind of, I think, warning signs that can sometimes indicate that your child is struggling and that it might be a good opportunity to seek additional kind of elevated levels of support. So some of those signs and symptoms would be, significantly depressed mood, withdrawing from friends, not getting out of bed, not taking care of themselves, failing grades, things like that, or significant irritability and anger, kind of angry outbursts. I think, though, putting that in the context of what is a normal response to a really, really hard situation, is that some of that is going to ebb into normal reactions as well. So you're really looking for more of a prolonged response, something that, over a matter of weeks or a month hasn't resolved and continues to get worse. And that's where I would say, I would definitely encourage you to seek out some additional mental health support, but also recognize that, really think about your own experience. Like, probably everybody watching today could benefit from having additional support, having somebody to talk to, a safe place to express your thoughts and your concerns. So I don't think there's ever someone who's a bad candidate for therapy, as long as they're willing to engage in the process.
Thank you so much, Sheila, Jenny, and Jill, for sharing your time and your expertise with all of us today. We really appreciate you guys and all of the wonderful information. And thank you so much again. If you would like to watch the session again at a later time, it will be available on the conference platform within the next hour by accessing this session and clicking on replay, or by navigating the on-demand tab in the platform hub. If you have any additional questions, you can send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. Be sure to visit our exhibit hall. Our next session will start in 15 minutes, so please join us for Dr. Thomas LeBlanc's session. And on behalf of the Aplastic Anemia and MDS International Foundation, thank you so much for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our session.